In this video, I will discuss some of the pros and cons of screening for cancer. So many of you may have wondered whether you should undergo screening and how effective is screening and why might it not be effective. My name is Dr. David Stewart. I'm a medical oncologist in Ottawa, Canada, and a professor of medicine at the University of Ottawa. And I recently wrote a book on cancer called A Short Primer on Why Cancer Still Sucks that can be purchased online if you're interested through Amazon Books. This is the second out of 16 videos that I'm doing on different cancer topics. And for additional details, you can see my book. Importantly, for your own personal health care, you should rely on advice from your own healthcare advisors. When a cancer cell develops, one cell divides form 2, 2 divide form 4, 4 divide form 8, 8 divide form 16, etc. So it's called exponential growth. And so this is why it appears that the cancer is growing more and more rapidly as it gets bigger. And to put this in perspective, all you have to do is think of a normal pregnancy, where you start as one cell, where it starts with one cell at conception, and then by the time that the baby's born, they weigh 3 to 4 kilograms and are already a trillion cells 9 months later. And so some cancers may grow even faster than normal pregnancies. With every one of those cell divisions, every time that a cell divides, there are mutations that are occurring, and those mutations affect the ability of the cancer to spread to other parts of the body. They may make it more likely to survive in other parts of the body. So as the cancer gets bigger, there are more tumor cells entering the circulation. For example, when a cancer is about 1 gram, on average there are about 1 million cancer cells already in the bloodstream by that time. But the good news is that many of them are sick and they will die. And that's why surgery and radiation can cure some cancers, because of all the tumor cells that are circulating in the bloodstream may be sick and they may die. But some may survive and grow in other parts of the body. The more cell divisions, the higher the probability that there will be mutations that will permit survival in other parts of the body. The more tumor cells overall, the higher the probability that there will be some that are able to survive in other parts of the body. So that's why finding cancers when they're small is important. It improves the chance of cure. Although sometimes even a very small cancer will already have formed distant metastases, will be incurable. Sometimes even very large cancers, there will be no distant metastases and it may still be curable. But it's just a risk. The bigger the tumor, the higher the risk that there will be additional cells present in other parts of the body, additional areas of spread in other parts of the body will make the cancer incurable. So if we can find the cancer when it's small, though, this reduces the risk that there will be distant metastases. And so that's where screening comes in. So screening can either find premalignant changes before cancer is developed, or they can find small cancers. For example, colonoscopy may find polyps in the bowel. If the polyp is left there, it may be developing into a bowel cancer that may spread and may become fatal. But if you find it when it's a polyp and remove the polyp, then no cancer develops. Similarly with pap smears, it may find the pap smear may detect cells in the cervix that are premalignant, and you get rid of those, then you prevent development of the cancer of the cervix. Or this screening may find small cancers. So colonoscopy might find a small cancer in the bowel, or a pap smear may find a small cancer in the cervix. Similarly, screening with CAT scans of the lungs may find an early lung cancer. Mammography may find an early breast cancer. PSA may find an early prostate cancer. And so by finding those cancers when they're early, if they're eradicated, then that just reduces the risk of there being incurable distant metastases. So it doesn't actually guarantee it, but it improves the risk, improves the probability of cure. So there are two ways of looking at the risk reduction. One is the relative risk reduction, and one is absolute risk reduction. By absolute risk reduction, say if the probability of dying from the cancer is 2% without screening, and you drop it down to 1% with screening, then 2% minus 1% is 1%. So that's the absolute risk reduction. But if you look at the relative risk reduction, you're cutting the risk of dying from 2% down to 1%. 1% is half of 2%, so the relative risk reduction is 50%. That sounds fairly impressive, but in fact, when you look at it in absolute risk reduction, it sounds far less impressive. But it's still important. The benefit of screening will depend on the amount of risk that you're at. If you're high risk, you gain a lot more than if you're low risk. To put it in perspective, women who are young have a relatively low probability of having breast cancer. So to prevent one death from breast cancer in women between the age of 39 and 49, you have to screen 1,900 women to prevent one death from breast cancer. The risk of dying from breast cancer is higher in older women. So for women between the age of 60 and 69, you only have to screen 380 women to prevent one death from breast cancer. And to determine whether somebody is high risk or low risk, we look at a number of different factors. So just as I mentioned, age is an important one. Cancer, for most types of cancer, they're more likely to occur in older people, so that older people are at higher risk and have more to gain from screening. But there's also some other things. So if you've got a strong family history for many types of cancer, that will increase the probability of developing the cancer. So people with very strong family histories may have a greater probability of benefit. Or if people have been exposed to certain things that could cause cancer, that may increase the risk. So a heavy smoker will have a much higher probability of benefiting from CAT scans of the lungs looking for lung cancer than a never smoker would, because the risk of lung cancer in the heavy smoker is much higher. Or patients with inflammatory bowel disease like ulcerative colitis will be at much higher risk of colon cancer than in a young person with no problem with the bowel. And so that a person with ulcerative colitis will have a higher probability of benefit from screening. So again, risk factors are important, and the higher the risk, the more that is to be gained from screening. Now, with screening, you can either make the test very sensitive to try to pick up as many of them as you can, or less sensitive. And there are pros and cons to making the test more sensitive. You may pick up more cancers, but also every time you do a test, there's a certain probability of a false positive, where something will look like a cancer that it's not. And the more sensitive the test, the higher the probability that there'll be false positives for most of these tests. And so that's the downside. So with most screening tests, a certain proportion of patients will have false positives. So for example, with mammography, one study described 9% of women having false positive mammograms. Because of the risk of false positives, that's why you just don't go with a mammogram by itself and initiate treatment. You have to do additional testing. So biopsies and or additional scans and things like that to determine whether it's a true positive or a false positive. Again, in the case of mammography, 9% of women may have a false positive, 0.5% will have a true positive. So out of every 1,000 women who are screened, 90 will have a false positive mammogram, and 5 will have a true positive mammogram. So that's a fairly low probability that it will actually be the real thing, but it's important to find those. So to determine whether it's a false positive, as I said, then you have to do additional testing, like a biopsy. But all that additional testing does carry some risk with it. So from a risk of bleeding or infection with biopsies, so a certain amount of radiation risk with additional scans, and also there's just the anxiety of waiting for additional testing to be done, and also there's the expense to the patient and to the healthcare system of having to come in for additional testing just to determine whether or not it truly is a true positive or a false positive. If a test is positive, it'll be a much higher probability it'll be a false positive in a person who's low risk than in a patient who's at high risk. And so example, again, if we have a screening test where the risk of false positive is 9% of all people have a false positive, but 2% will have a true positive, then out of every 11 patients with a positive test, 9 will be false positives, 2 will be true positives. If the probability of a true positive is 0.1%, then out of every test that's positive, 9 will be false positives, 0.1 will be true positives. So the probability of false positives will be very, very, very high of all the tests that are positive in that low risk group. So with respect to whether an individual should undergo screening or not, there's never any one right answer. Because even in low-risk patients, screening can be of benefit. It's just that it's going to be an awful lot of false positives and a very low probability of true benefit. But there are still some circumstances where it might be considered. But the right answer for you as an individual is to discuss this with your healthcare provider, and also think carefully about the implications of false positives and just about having to go through the test. But there's no one right answer, so you discuss this with your healthcare provider before making a decision about whether you undergo a screening test or not. Okay, there's also a bunch of other things that I've discussed about screening. Again, my book, A Short Primer on Why Cancers Still Suck, that can be purchased online through Amazon Books. I hope that you have found this video helpful. Thank you.